together. My best to represent. Okay, are you all seeing the slide screen?
Yes, we are.
Yes, okay, great. So we have no disclosures. So today we'll be talking about details of formulation and dosing of buprenorphine, kind of getting into some of the more details of prescribing. And some of this, a lot of you will be very familiar with, and I'd love to hear kind of ideas about this moving forward after the talk too, if we have a little time for that. So the objectives are to describe the differences between the different formulations of buprenorphine, to discuss the difference between protocols of home-based initiation or induction and clinic-based starts for buprenorphine, to learn about dosing and duration of maintenance treatment, and also discuss management of diversion, and to create a plan for managing the process of medical withdrawal from buprenorphine. So what are some of the formulations out there? So this slide kind of summarizes what is available in terms of Suboxone or buprenorphine. You can see the sublingual form in both the film and the tablet. Comes in a variety of doses. However, usually what's most available is either the 8 mg/2 mg film or tablet. And pharmacies will, though, often cover these other doses. And then the tablet that's called Subsolve is covered by some insurances. And so it's just good to be familiar with it, and also to realize that the equivalent dose of Subsolve tablet, the buprenorphine 5.7 mg, is equivalent to the 8 mg in the Suboxone. So sometimes it may be easy to see the 8.6 and make it more, think that that's the equivalent, but it's the 5.7. There's also the buccal Bunavail form, which I have not seen used here, but I know that it does, many people will prescribe that. And then there's the mono product, right? So just the buprenorphine alone without the naloxone component. The implant, we no longer use that. The injection for Sublocade, however, sorry, was someone trying to comment? Oh, okay. The Sublocade, we will talk about that more, that injection, which is given monthly. So again, the buprenorphine naloxone should be used for treatment of opioid use disorder. And again, this is in contrast with Suboxone's not used for management of pain. The naloxone is, unlike buprenorphine, which certainly off of the X waiver has indications for pain, and it can be very effective. So the naloxone component, the reason again for that combination is that it's not well absorbed if it's taken as prescribed, so sublingually. And so if it's injected, if it's, for instance, crushed and injected, it can precipitate withdrawal in an opioid dependent person, someone who's already tolerant. And so it's really included there as an anti-diversion mechanism to decrease the injection of the medication. So again, this goes over the 3 sublingual forms. And we really just are using mono product in pregnancy still, although certainly there's movement to the combo product as well. But we particularly, if we're going to prescribe it, would be for pregnancy, and if there's a documented allergy to naloxone, which is quite rare, can happen. I think I've seen one rash that seemed to be clearly related, but most of the time the combination product is preferred. And what about film versus tablet? This is really driven by third-party considerations, usually like pharmacy availability and insurance coverage. Some patients may request it and seem to have a preference based on prior experience of certain taste or of one or the other, but the film does tend to dissolve quicker. And then there's a possibility for the individual wrapping of the film to possibly reduce diversion and maybe increase safety in terms of just getting into the medication, delaying, for instance, say a child from getting into the medication. So as far as buprenorphine treatment options, really the current standard of care is self-administration. Again, there's many doses and formulations. It's really accessible, hopefully more and more so. There is more diversion risk with the patients taking home, especially if there are longer prescriptions, and there's moderate cost at times, but most of the time this is covered now by insurance. The injectable form, again, is the other option. Patients will just present to clinic once a month for this. There's a growing number of potential doses to be given and routes of administration that are also under study. It has a closed distribution system, so really not a risk of diversion with that one. With some seeing enhanced treatment adherence, and there are higher costs though, and so usually there's a process to go through in terms of getting the medication approved by the insurance. But the case can be made. Usually, I would say that for the injectable, if someone has a very clear reason why it's hard to administer at home, or they've tried it before and they're not doing as well in terms of their goals for treatment on it, you can make a case to have this injectable, the Sublocade injectable buprenorphine. So let's talk about the buprenorphine initiation at home. Is it safe and effective? Yes, very. This has been well studied. Josh Lee has a great paper about this that looks at this versus in-clinic initiation in terms of outcomes, 7-year outcomes, and he and his team found really pretty good results in terms of adverse events, no serious adverse events, low likelihood of precipitated withdrawal, and really comparable to in-clinic at 3% for precipitated withdrawal, prolonged withdrawal experience of 4%. And really this is key, that the treatment retention was at least as good as in-clinic initiation. So at 57 weeks, still having median treatment retention. What is the process? So really, pretty much everyone is a good candidate for an at-home start for Suboxone or buprenorphine. You might consider that someone who has a really low tolerance for the withdrawal may not be such a good candidate and may do better having supervision and having help through the process in the clinic. But oftentimes it's good to also just ask about the support of family members, other people who may be able to help out at home. Certainly when patients are transitioning from methadone, that can be a trickier initiation, and sometimes having that in the care of the clinician can be more effective. If a patient has cognitive impairment, and certainly along with that, if there doesn't seem to be good support to help them through the process at home, that would be a reason to have them still come to clinic to start. And then if they have untreated or unstable psychiatric conditions or suicidality, we want to prioritize management of that. And certainly if they have no prior buprenorphine experience or a significant fear of withdrawal, that may be a reason to have them come to clinic. I would say this is less and less. Patients oftentimes, if you ask them, have already had the experience of trying it, whether prescribed or not. And sometimes that is a guide that can be helpful for a conversation of how to start it successfully at home. So this is really the traditional approach that you hear about both in like the waiver training and in other settings as far as starting buprenorphine. Really, we're instructing people to wait until they feel very lousy, so feel like they're really experiencing significant withdrawal. And time frame matters too, but really you want to make sure that they're paying attention to their symptoms mainly, but at least 12 hours since the last use of short-acting opioids such as heroin, and at least 24 hours since the use of long-acting opioids. You can consider providing them the SOUS scale, and so that they can kind of also monitor it at home if that seems appropriate to have as a guide, and you would instruct them to target the score of at least 17. We used to gear a little bit lower, but certainly we'll talk more about this with some of the with the influx of fentanyl. This has changed, and we're targeting for even higher scores now before starting. And then again, the traditional approach is to start with a 4 milligram dose. So having them cut the strip or break the tablet if it's an 8 milligram in half. and basically repeating the administering under their tongue and then repeating that dose every 1 to 3 hours if the withdrawal continue for a total dose of 12 to 16 milligrams on day 1. I say this is the traditional approach because oftentimes now, especially if it's clear that someone is tolerant to opioids, your goal would really be closer to 16 to 24 milligrams on day 1. And definitely emphasizing that it's okay, and we would encourage them to call the clinic if they have precipitated withdrawal at home. This is just a copy of the sounds that you can give them. You can see here that they can kind of score themselves, and this might be a helpful tool if they're feeling uncertain or perhaps a family member is feeling nervous about a home initiation, that this can be a little bit more of a guide. So what about day 2? Then you tell them to take the total dose that they took kind of in increments on day 1. You tell it to take the total dose in the morning on day 2. Be in touch with the clinic to check in. And then later in the day, if they haven't on day 1 gotten to that maximum dose, if they're feeling withdrawal on day 2, they can take additional 4 milligram doses until they reach up to 16. And I've added up to 24 because certainly that may be necessary. Basically, our goal, right, is we want to get them comfortable as quick as possible and avoid the risk of feeling like they need to use. And then on day 3, if needed, if they haven't quite gotten to, they're still feeling a little unstable. And sometimes those first few days, certainly when the brain is adjusting, it can feel unstable, and the withdrawal, if anywhere precipitated, it may take a little while for that to go away. You're going to be adjusting their doses, provide enough medication for the first week. And then, of course, depending on what your clinic setup is, if you're able to see them sooner or have walk-in capability to see them sooner. But 1 week is usually a good target. You want to try to get, again, to that target dose quickly. And then after that, you can allow for about 5 to 7 days to, if you haven't reached the high end dose of 24 milligrams, you can allow for a few more days to see if you're going to need to increase any further based on their symptoms. So how long, again, are you waiting? We talked about the short-acting opioids, at least 12 hours before starting, most long-acting 24. Methadone is going to be even longer because methadone has such a lengthy and variable half-life. And so you're going to be looking at least 48, sometimes up to 72 hours. And again, we want to discuss always the possibility of precipitated withdrawal, which most patients are aware of that, but definitely talking about it, not to discourage them, but to kind of help them prepare for it if it should happen. And then if it doesn't, then that's good. And that we can treat it. We can offer them medications that will help them through that. And as far as transitioning from methadone, usually we're aiming for getting down to 40 milligrams or less for at least 1 week, and then being off of methadone completely for 48 to 72 hours. Again, you want to provide medication for symptomatic management, so certainly they may have more of a need for this with these transitions. Medications such as clonidine can kind of help with that internal sort of irritability feeling on CS. The ibuprofen help with cramping, loperamide for their stomach, trazodone, etc. Hydroxyzine may be quite helpful for anxiety and insomnia. Then again, you can start with that 4 milligram once in significant withdrawal and go up. And there may be some indication for microdosing with transitions from methadone, and we'll talk about that in a bit. As far as precipitated withdrawal, again, you want to discuss this ahead of time. Don't wait for it to happen. And if it's observed, we don't want to stop the buprenorphine initiation. So definitely want to counsel them to continue to push through it, because eventually those receptors will become saturated by the buprenorphine that holds on to them more strongly with greater affinity. And even though it's a partial agonist, and so had that precipitated withdrawal, right, it will take over and they'll eventually feel better. And then you can recommend that if they're able to come into the clinic, if they do have precipitated withdrawal, then certainly they should. So we'll talk a little bit about microdose inductions. And these are small buprenorphine doses that are administered in a stepwise manner to decrease that risk of precipitated withdrawal and pain. They might be especially useful for patients who have chronic pain or if they're unable to stop using other opioids. And the real key difference is these inductions do not require withdrawal prior to induction, and take advantage again of what I was saying, that buprenorphine has that higher affinity at the mu opioid receptor, and so will eventually wash out the other opioid. And then once that occurs, usually, and I'll show you this slide, I think it's coming up soon, the pre-existing opioid can then be tapered after the induction has already started with buprenorphine. So here's a visual to look at that. You can see that you'd be using a lower dose film, right, for these micro inductions. So the 2 milligram, because it'd be hard to get to a 0.25 milligram dose with 8 milligram film. But on day 1, so someone is still, say, on their prior opioid, let's say they've been on oxycodone, and they start the buprenorphine at very low dose to make this transition. And by day 2, then they can go up to 0.25 twice a day, and so forth. Stepwise, you can go up to then half a milligram twice a day, then a milligram twice a day. Then by day 5, you're getting up to the full 2 milligrams twice a day. By day 6, stepping up more to 4 milligrams twice a day. And really the goal at day 7 is increased to 12 milligrams. And then at this point is when then you would continue or increase. This really can be increased further and taper off, though, at that point, and hence avoid the precipitated withdrawal. A question from doses. Thank you for that question. So we'll talk briefly about maintenance. So the FDA maximum dose is 32 milligrams, but most insurances will just cover up to 24 milligrams. There are some patients, and I think some cases to be made, especially now with fentanyl here, for that patients may need higher doses. The duration of the prescription is really tied to how the patient's doing and what their goals are. And there's no rule for how long the prescription should be, but most of the time it's recommended to start with weekly prescriptions at each visit for about 4 visits. And then if they seem to be doing well, you've got them on the dose that seems to be helping, then you can transition them to 2-week prescriptions, again, for about 4 cycles, and then monthly. And then you can go up to a monthly prescription with actually, we would do up to 2 refills if they're, really stable and well and not needing to check in sooner. And then talking briefly about diversion management, we do recommend doing a urine tox screen at each refill, and you can check for the buprenorphine in clinic, so you have a tool to discuss more efficiently with the patient there. But also these can be sent out as well to check for actual metabolites from time to time for the buprenorphine, just to make sure, especially if you have longer prescriptions, that it's being taken as prescribed. We do check the PDMP every time you're prescribing. You can do 48-hour callbacks at our clinic. Our nurses have a list where they will, and patients understand ahead of time that they may during the year get a call asking them to return within 48 hours of the call and bring the prescription in with them to do a film or a tab count. Again, it's not a requirement, but this can help in terms of this diversion management. And then certainly safe storage, and we recommend lock boxes if possible, but also just to make sure, also for safety reasons, that no one's getting into it who shouldn't. And then we'll just talk briefly about high potency synthetic opioids. So most people are doing, getting onto buprenorphine with these. I would say doing fine with them. I think that it can be harder, these initiations for sure, but we do still recommend that, they seem to be doing fine once they transition on to the buprenorphine. There are increasing reports of precipitated withdrawal, and really, though the buprenorphine treatment retention and abstinence rates seem to be equivalent in this study from Wakeman, looking at heroin versus fentanyl. So why does there seem to be more precipitated withdrawal with the synthetic opioids? Not totally clear, probably maybe some reduced renal clearance. It's also a lipophilic drug, so it could be more long acting over time. And it's interestingly not seen when the fentanyl patch is replaced with the buprenorphine patch, which sometimes can be used, especially we've seen these inpatient transitions from fentanyl to buprenorphine. So the microdose approach is really starting low again. You go slow, and then you're waiting longer into withdrawals, sometimes before starting, especially with fentanyl. So you're going to aim for initial COWS score that's higher than the traditional 8 on the COWS for short-acting opiates. For fentanyl, you'd be waiting for a COWS of at least 13. Self-report is considered pretty unreliable, so you really want to make sure that they're basing it. And this is why sometimes having it done in clinic or inpatient is most beneficial. Definitely want to be providing them, again, all the counseling and education as far as the process, and providing them with those adjunct medications. And then really going this one approach of going slow, so 1 to 2 milligrams every 1 to 3 hours, and then aiming for that dose of 16 milligrams total, and maybe up to 24 milligrams. Is what's recommended for the microdose approach. And then remembering that some may need methadone. So these transitions can be hard, and if it seems like it would be safer to get them over to methadone, if it's not working, to transition them to buprenorphine, then just remembering that as an option. This is a case study from Antoine et al. From 2020 that looked at 4 individuals who tested positive for fentanyl, and compared patients who were started in the sort of more traditional conventional buprenorphine induction versus 2 with the microdose induction with using multiple 2 milligram doses. And they found that patients were less likely to experience precipitated withdrawal from this sort of microdose revised approach. And then just to talk briefly about this macrodose approach, this is a really, I think what we're kind of turning to more. The evidence is growing, but still small. But certainly with fentanyl, I think that a lot of us are turning towards this macrodose idea, which this study, a case series of 5 individuals by Mariani, which was also published in 2020. You can see here that they basically gave people a test dose of buprenorphine to ensure that they weren't going to precipitate withdrawal. And then really the idea was to do at least 2 consecutive days at 16 milligrams before giving the injection, but they found that really for treatment retention, that if they gave the extended release 300 milligram buprenorphine sooner, that they're more likely to retain people in treatment. And you can see here, as far as the status of these folks, so 2 of them, I believe, got the injection on day 2, and 3 of them got it on day 3 after having their initial sublingual dose. And there you can see then what happened to their COWS scale over time, went down significantly by day 4. And they had great results in terms of given a small case series, but in terms of no opioid use and patients continuing on the buprenorphine injections. And this is a phase 2, which I'm not actually sure. I saw the first one in the published version. I'm not sure if this one has been published yet, but this looked at actually giving them the injection on day 1. So quick test dose of buprenorphine sublingual. You can see there at the 24 milligrams, if they tolerated it, they went on that very day to give them the injection, and then had really improved results in terms of lowering COWS scales and continuing in treatment. And then just briefly about withdrawal, I realize we're already at time here. There's no data to guide us on how long to treat someone, but really we want people to stay on this treatment. We know that it works. And we know that there's high relapse rates when people withdraw off of buprenorphine. So we want people to stay on this long term and continue maintenance as long as the patient is benefiting from treatment. Again, there's no real difference in terms of the timing for a withdrawal. So if the patient really does want to or need to taper off of buprenorphine, there's no difference in, for instance, in the 7 versus 28-day tapers. And at 1 month, the opioid negative urines were low. So you can see that really not great to come off of the medication. And again, it's because of that loss of tolerance, right? So the risk of overdose is even greater after withdrawal because patients' tolerance has gone down. And those who are undergoing medical withdrawal really all should be warned so that they have an informed idea going forward about the risks associated. And if, again, they want to go forward with this, we want to make sure that we discuss that their goals have been met, they have more stable social networks in place. I never talk about it in terms of, a time frame, because sometimes people will come in starting on buprenorphine and say, how soon can I get off of it? And there's not really, I wouldn't say months or even years. It's really if they're going to do it once these goals are met. And then really important to follow the patient's pace with it and to encourage them to remain engaged in treatment and therapy even after going through a taper. And then you could consider the naloxone injection after completing the withdrawal period and being off of the buprenorphine altogether. So I will stop there and see what questions there are.